case having done with left-hand bifurcation in patient of the ST elevation mitral infarction. There is no conflict of interest. Coming to the case, the 60 or 65-year female having history of diabetes and hypothyroidism on regular medications, having chest pain of 6 hour duration. This shows there is ST elevation of lead 3 and IVF and ST depression of ventral leads. The echo shows there is a hypokinesia of lateral wall, infralateral wall, EF was 45%, and this is the acute infrared STEMI. Coming to this is angiography. This angiography shows there is LCX is 100% occlusion, there is significant disease left main, and there is the LED lesion extend from the proximal to the mid segment, and there is large diagonal which has osteal significant disease, and RCA is minor disease. So this is ST elevation mitral infarction setting with involving LMCA. So what is the plan of management? This is the bifurcation involving LCX 100% and the left main bifurcation, and there is LED diagonal bifurcation. The Syntax score is 22, which is favors both CABG and PTCA. This, what is the plan of case? It is acute setting, whether you can wait for this bypass surgery or go for the primary angioplasty. And if you go for the angioplasty, what is the approach? Whether you go for the radial femoral. Challenges in our case is, this is the LCX is 100% occlusion and involving left main and LED diagonal bifurcation. And if bifurcation stenting is chosen, which technique should be preferred? We have chosen a plan for femoral artery approach, taken the XB LED guiding catheter, and our plan was after the opening of the LCX plan to the mini-cross technique of left main bifurcation, and the LED diagonal is provisional stenting under IVUS guidance. But we have during the procedure we have changed our plan because of complications. After this wiring done, both LED and LCX by the our usual workhorse wire, that is run through floppy, and after that this lesion is pre-dilated and the flow is LCX is established. After the flow is established, then we have taken the IVUS images from the proximal LED to left main. There is fibrofatty plaque involving proximal LED, also there is left main significant plaque burden, and the proximal LED is the MLA is 2.3 and the MLA is 4.3 and diameter is 2.3, and the left main is MLA is 5.6 and significant plaque burden. After this IVUS run, then we have wired both diagonal and pre-dilated diagonal with 2.5 and LED also pre-dilate with the 2.75. After the pre-dilatation diagonal, there is some dissection noticed in the diagonal. So there is no option, we have to change our strategy from provisional stenting to the two-stent technique for the LED diagonal bifurcation. Then diagonal lesion has been stented with 2.75 and 60 millimeter, and after this there is successful, there is no edge dissection of the distal diagonal. Then both wire and stent balloon has been removed, and the diagonal stent has been crossed with the 3 into 12 millimeter balloon at 16 atmosphere pressure. After the crossing, the pot has been done, the LED from the proximal to the mid LED has been stented with the 3 and 36 millimeter long stent, and after deployment of the LED stent, this pot done. After the pot, the diagonal wire has been recrossed, and after the recrossing the diagonal, there is final kissing done with the diagonal LED with 2.75 keeping in the diagonal and 3 millimeter balloon in the LED, and final kissing balloon with the LED diagonal. And after the successful LED diagonal bifurcation, now our challenge is L6, that is left main bifurcation. The L6 is long segment disease. So we have chosen a long segment, long stent of 2.536 stent, and keeping the one balloon, that is 3.5 12-meter balloon in the left main across the left main, we have deployed that L6 stent, keeping 1 to 2 strut inside the left main, like in mini cross technique. And after this deployment, this L6 stent has been crossed with 3.5 12-meter balloon. After the cross, this another stent, that is a left main to LED, we have chosen with the according to the IVUS, our images interpretation. The 4 in 28 millimeter balloon stent has been taken from the left main to up to the proximal LED. This stent should not cross the LED diagonal bifurcation. And after deployment of the left main stent, we have done the pot with 4.5 into 6 millimeter balloon. And after the pot done, this L6 again recross with another wire with non-distal strut. Then final casing implantation done L6 with 2.5 12-meter balloon in L6 and 3.5 in LED. And after the final casing dilatation, repot done with the same 4.5 into 6 millimeter balloon at 28 atmospheric pressure. This is the result of LED diagonal bifurcation. This is the pre-result and post-result. And this is complete apposition of the LED stent, and there is diagonal ostium is free of stent strut. This well open of the diagonal ostium. Similarly, this left main bifurcation also, this pre-result, this is the post-result, and this L6 means ostium also well open, and LMCA is well open, and MLA of left main is 13 millimeter square. So it is an acute STEMI setting with the left main, and we have planned for the one mini cross technique on provisional stenting, but ended up the true bifurcation stent, that is 2 mini cross techniques because of the diagonal ostium dissection. So take home message our case is acute coronary syndrome, that is ST11 patient with the left main bifurcation with low Sinta score can be managed with angioplasty, as similar outcome with the bypass surgery. And if left main should be taken with the larger guide catheter, the 7 branch should be preferred. And if significant side branch is there, bifurcation stenting should be done. If complication like side branch occlusion or dissection should be preferred from the provisional to the double stent technique. Double bifurcation can be measured with angioplasty with proper planning, and IVUS is essential. Usually should be left main bifurcation for long-term outcome. Thank you.